Hey everyone, this is Heather White, and I'm going to be presenting on glomerulonephritis, more specifically rapidly progressive glomerulonephritis. I picked this topic because although it's a rare renal condition, it's often very severe, and it's important that family practitioners and mid-levels can quickly detect the signs and symptoms of this disease and have a prompt referral to nephrology. I'll be going over some of the general features and background, the clinical symptoms on presentation, the diagnostic workup, and then treatment and prognosis. Rapidly progressive glomerulonephritis, or RPGN as I'll refer to it from now on, is a rare but serious renal condition. The disease dates back to Hippocrates, who first described the disease as a back pain followed by blood and protein in the urine. Richard Bright, who is pictured here, is credited with being the first to report the clinical symptoms in 1827. This created a formal diagnosis, and over the years, the disease has been classified into three groups: type 1, type 2, and type 3. Type 1 is caused by antibodies to the glomerular basement membrane and is most often associated with Goodpasture syndrome. Type 2 is immune complex mediated and includes conditions such as post-streptococcal glomerulonephritis and lupus nephritis. Type 3 is caused by anti-neutrophil cytoplasmic autoantibodies and is associated with small vessel vasculitis. This also happens to be the most common type of RPGN. The disease only affects 7 out of every 1 million American persons and affects Caucasian Americans more than African Americans at a ratio of 7 to 1. The reason for this is not really clear. Patients with RPGN will often present with vague symptoms of aches, fevers, arthralgias, fatigue, nausea, and generalized weakness. The symptoms may differ depending on the underlying cause of the RPGN. They may also present with elevated blood pressure and peripheral edema. But specific exam findings will differ depending on the type of RPGN present. Those with type 1 RPGN, due to Goodpasture syndrome, often present with signs of pulmonary compromise. These patients may complain of persistent cough and hemoptysis. Type 2, which is vasculitis-associated glomerulonephritis, may present with purpura and other dermatologic abnormalities such as rash and pruritus. They will commonly report a recent upper respiratory infection. Type 3 can present in a variety of ways depending on what has caused it. Further testing will likely reveal organ damage leading to the diagnosis. And this is because type 3 can be caused by any of those small vessel vasculitis. Several tests are required to make a formal diagnosis of RPGN. The testing for RPGN will include a CBC, a CMP, and a urinalysis. The complete metabolic panel will show an elevated creatinine, and the BUN may or may not be elevated. The urinalysis will show proteinuria and hematuria due to glomerular damage. And here we have a picture of the glomerulus, and this just shows proteins entering the glomeruli, and you can see how large they are in comparison, and it's evident why it will cause damage to the glomeruli. Other tests may be ordered depending on the suspected cause. In those who have a rheumatologic history, or if one is suspected, a C-reactive protein and an ANA or anti-neutrophilic antibody may be ordered. Imaging studies are not particularly helpful in diagnosing RPGN. However, it is important to order a renal ultrasound prior to performing a biopsy, just to make sure that all of the renal anatomy is normal and intact. A renal biopsy is required to make a formal diagnosis of RPGN and also to distinguish between types. If antiglomerular basement membranes are present on biopsy, a diagnosis of type 1 RPGN can be made. Steroids are the main drugs used to attempt remission of disease, but they are not strong enough to use alone. It has been shown that patients on steroid therapy alone typically relapse while still on therapy. Because of this, an immunosuppressant, such as cyclophosphamide, is often added to the regimen until the patient has achieved remission. Once a patient has achieved remission, they can be switched from cyclophosphamide to azathioprine, which is effective but doesn't have nearly the immunosuppressive effects as cyclophosphamide. Plasmapheresis has been shown to be beneficial in use with steroids and cyclophosphamide for patients with severe renal impairment. However, it hasn't been shown to be beneficial in patients who have RPGN caused by lupus nephritis. Some studies have shown that mycophenolate has been helpful for patients with lupus nephritis and also anti-glomerular basement membrane nephritis. One study showed that rituximab was successful in treating lupus nephritis in combination with cyclophosphamide. However, this combination of drug therapy cannot be used long-term due to the immunosuppressive effects of both of these drugs. This is an algorithm that shows us the treatment for RPGN. So, like I said, the mainstay of treatment of RPGN is high-dose steroids in combination with an immunosuppressant such as cyclophosphamide or mycophenolate. If the patient responds positively to treatment, then they should remain on a low dose of steroid and either mycophenolate or azathioprine. Cyclophosphamide should not be used long-term due to its severely immunosuppressive effects. If there is no response, the patient should remain on cyclophosphamide, mycophenolate, or a monoclonal antibody such as rituximab in an attempt to achieve remission. Should the patient achieve remission with this regimen, they will then be switched over to low-dose prednisone and either mycophenolate or azathioprine. RPGN itself cannot be prevented. However, early treatment is crucial in preventing the progression of disease to end-stage renal failure and the use of dialysis. Patients who present with a high serum creatinine greater than or equal to 5.7 or who require dialysis at presentation have a very poor prognosis. Patients presenting with 80% or more crescents on renal biopsy at the time of presentation also have a poor prognosis. Because early treatment is key to survival, it is imperative that if a family practitioner suspects RPGN, that aggressive treatment is started or a prompt referral to nephrology is made. It has also been shown that prompt treatment of strep infections with antibiotics does not prevent the development of post-streptococcal glomerulonephritis. Patients on immunosuppressive therapy should be educated on the side effects and instructed to present to their primary care physician if they show any signs of infection or are exposed to known infected persons. These are my references, and thank you for watching.